Live stream. I'm Dr. Deuk. We're getting ready to start our third surgery for today. We've only broadcasted two because one of our patients did not want to broadcast. We always give our patients a choice. This patient here actually has two herniated discs. One is at L3-4, another one is at L4-5. And that is what I'm aiming for right now is the L4-5. Shot. So far, looking good. So I'm up against the facet complex. I'm right at the foramen. I'm literally touching the facet medial surface, wrapping around. Shot. Is he comfortable?
Seems like it right now, yeah.
Good. Shot. So I'm heading towards that disc right there. You guys see the disc? We're off on orbit. You see the orbital problem at 5? So we're doing 3, 4, 4, 5. Everybody agree? And we're aiming for 4, 5. I don't know if I said 3, 4, but I meant 4, 5. We still have an orbital issue, I think. Let's try something else. That may be better. He's got short pedicles. You can see the short pedicles. But that looks good right there. I think we can stay there. Is he comfy? Shot. I'm up against the herniation right there. So that's our first one. And you notice if you watch my surgeries enough that the hardest disc to get to is L5-S1. In his case, he doesn't have a problem at L5-S1. So we're not going anywhere near that. We're going to be treating 3, 4, 4, 5. And it turns out that his 3, 4, and 4, 5, I believe, are the source of his pain based on his physical exam and his MRI scan. Is he comfy? We're making our incision. Our incision is going to be a 7mm incision. 7mm is about 1/4 of an inch. A little bit bigger than 1/4 inch. And we're going to go for the second disc, which is the number 3, 4. You could see the 3, 4 is a little more collapsed. Any way you can make 3, 4 look better for me? Shot. That's looking good. Definitely heading in the right direction. Shot. Yeah. You can see the pedicles are lined up nicely. Shot. It's a little too high. Shot. That's better. Shot. All right, so let's get an AP. Just make sure things are looking good on the front back view of the x-ray. So Henry, do me a favor and show our audience, why do herniated discs cause back pain? Or neck pain, for that matter. What's the mechanism? Nice.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
And welcome back. So our patient, just to give you some history, has had lower back pain for
15 years, but he's had the symptoms that have been really bothering him since August.
15 years. Okay? Back pain for 15 years. And it's gotten a lot worse in the last year. Okay? And that's pretty typical for back pain. Back pain starts out intermittently, episodically, it comes and goes. Maybe in the beginning it goes for much longer periods of time than it's there. And people just kind of modify their behavior, their activities to make the back pain feel better early on in the disease. And the back pain goes away, then they get more active again, they do something, and then they set it off. So it's a cycle of getting better, getting worse, getting better, getting worse. And then after a period of time, and everybody's different, it really settles in and just stays there. It's constant, and it's just daily, okay? I'll give you an example. I've got hip pain, right? Started out from an old soccer injury back in high school, and I didn't have any pain for 20 years. And then only when I really went crazy in the last couple of years with running, a lot of running, then I started getting some hip pain. But then I stopped running and it went away. And then now, if I just do too much walking, it comes and it stays there. And eventually, it's going to be every day and constantly hip pain. That's what happens with arthritis of a joint. You injure the joint, you get inflammation, the inflammation sets in, grows in tissue, called inflammatory tissue, and then eventually it becomes constant pain with anything you do. So that's in my future, okay? I got to deal with that in the future. But for people with back pain, it comes from the disc about 90% of the time. And specifically, it comes from a tear in the back of the disc. That's what we discovered here at Deuk Spine Institute. That's why nobody else in the world will tell you this, because they don't know it yet. So we discovered this tear, a little tear in the back of the disc causes all the back pain. And I go in there with a laser and I clean that tear, just the tear, clean it, the pain goes away, 100%. Happens every single time. Okay, now people have other causes of pain too. Sometimes they have facet joints or sacroiliac or piriformis, and sometimes they have a fracture. Very rarely do they have infections or tumors, but most commonly it's a disc problem. And so I believe this patient has pain. In his pain on exam, he said it's right in here. And I looked at his MRI, and guess what's right there? Well, he has 2 discs that are damaged on the MRI with tears. So we're going to test that to see if that's the cause of his pain. Is he awake?
Hey, my friend. Hey, buddy, can you open your eyes for me? Can you open? Good job. Can you open your eyes?
So we want to make sure he's awake before we get
Can
started.
you open your eyes for me?
He was sleeping nicely, comfortably, which is how we want it. Hey, are you awake? Are you awake?
Can you open your eyes? We have some questions for you, my friend.
He's still a little too sleepy.
He's getting
All right. So do you have any questions from our audience while we're waiting?
No current questions.
Now, to determine whether these discs truly are causing his pain, we do a simple test called the discogram. The discogram was developed by some other doctor years ago. I don't even know who developed it, but
Hey, my friend.
it's pretty ingenious. You put a needle inside a disc. You want to know if it's a painful disc or not. You inject a little bit of saline in there. Saline is, biologically inert, physiologically buffered to the right pH. Long story short, a non-painful disc, when you inject some saline into it, it won't cause any pain. But a painful disc will. And so it's a confirmatory test to see whether or not these discs are the cause of his pain. Okay? By the way, here's our blood loss so far for the whole surgery. A couple of drops. How are we doing? Is he awake?
Hello. Friend. Hey, open your eyes for me. Can you open your eyes?
We just need you awake for a few minutes while we do some tests. Are you awake?
Are you okay? You open your eyes.
All right. Well, we'll give it another minute. Why don't you run our animation video that shows how the Deuk laser disc repair procedure actually works in the lower back to cure back pain.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Don't move.
Don't move.
All right, he's awake now, so we're gonna test his discs. But he's not happy being here. He's moving around. How bad is that on a scale of 1 to 10? All right, let's just put him back to sleep. Berndes.
How are you doing? You okay? You okay? He's waking up now.
I can't have him come off the table. No, it's fine. Shot? All right, so we got 2 discs with 2 tears. No, you're fine. Leave it, leave it. We need you to lay still, my friend. So we didn't get an answer as to how much pain these discs are causing him, but we certainly will use the dye to stain the nuclear material so we could see the annular tear. Shot? Let's get the lights. When you get a chance, let's get the light back down. Shot? You see the guide wire? Shot? We're at the top disc, which is 3-4. Shot? It looks like it's coming out the end there, right?
Yes. Yeah.
Shot? I see it there, right? You see it? Shot? Yeah, because I'm pulling back the needle and the guide wire is staying there. Shot? All right. So you can see the guide wire is in position on the x-ray at L3-4. Our patient is back to sleep. When he was waking up, he was very agitated. We call it agitation, psychomotor agitation. It's when my body is moving all over the place, but that's pretty common to see when people come out of anesthesia. Long story short, I was not able to get his response on the discogram because he was moving around too much as he was getting lighter, and we don't want him coming off the table. It's a safety issue, so we're just going to have to live with the discogram being a non-evocative discogram. Shot. So once again, we're going to use our dilator to get into the disc. Shot. I think he's tightened up pretty good there. Are you have him optimally sedated?
Trying my best.
All right, that's good. So we are now inside the disc with the endoscope. Okay. Shot. Perfect. You notice the tube is actually in the back part of the disc, which is where the tear is. Any questions, Henry?
No current questions, but we do have a comment from Janet Parker on Facebook.
Hi, Janet. Thanks for commenting.
And she commented, share, share. And I believe she will spread this message.
Share.
Share, sharing the message, spreading the Deuk laser
yes,
disc repair.
thank you. We agree. We want to get the word out. I was just talking to a patient in Louisiana who his insurance company wants him to have a fusion, which is a barbaric surgery and totally unnecessary. I've already seen him and saw his MRI, and he'd be a perfect Deuk laser disc repair candidate. The reason the insurance companies want fusions is because most patients recommended for a fusion won't get it done. So then they don't have to pay. All right. Here we are inside the disc. I need you to lower your IV pole. Over there.
Good?
Yeah. This is degenerated disc right here, the blue stuff. I don't know if it maybe fell off. That is a herniation right there. Uh-huh. See how firm it is? It's all scarred up. Another. This one broke. Well, for those of you watching, you are more than welcome to ask questions. If you have a question, just type it up. There's a herniation. Let's show them. Let's take a look at this herniation right here. I just pulled it out. You guys see this?
Yes, we do.
Is it a pretty good, you see that right there? Good size?
Yep.
Just came out of the tube. Can you see that right there?
Yes.
Yeah. Oh yeah, we got another one earlier. You guys see?
We see everything. Yep.
That's the earlier one. So clearly those are not normal pieces of nucleus pulposus. Those are herniations. And they're inside the disc because we just shoved them back in. Remember, I went with the dilator through the tear that the herniation came out of. Here's another one. Just a lot of herniations at this disc. And they're coming out in what we call fragments. And a lot of people think a herniation is just one event. There's another big one. But a herniation is actually multiple events. So this patient here has had back pain for how many years? 15 years. But the back pain is from the herniations. But the back pain got worse over time. Here's another big one. I mean, look at the size of this one here. Lights on.
Lights on, please.
Let's show all of them.
All of them?
Yeah. So this is a good case for seeing, look how big that herniation, look at it, came out of the tube. You guys see that?
We see
Henry?
it. We
Yeah.
see it.
So Luis has got a whole collection of them now.
Yeah. Oh,
We're going to have Luis show you our collection of herniations. You don't usually see so many herniations in one patient. Okay, you want to show them? So here they are. Look at those things right there. It's like a family of herniations. You got mom and pop and you got the kids. All right. Yeah, lights off. There's a few more pieces in here. Everybody wants to know, Dr. Deuk, when you take the herniation out, there won't be any disc left. Well, you're not understanding what a herniation is. A herniation is not normal disc. It's not inside the disc. It's outside the disc. So when you see the herniation come out, it doesn't mean we're taking the disc out. It's already out. We're just removing it from the patient's body where it's causing symptoms. They herniated the disc themselves. That's when they spit the piece of herniation out. That was a long time ago. And there's no going back and putting it back, unfortunately.
we have a question.
We will take your questions.
This comes from Sunil Patel on Facebook,
Hello, Sunil.
and they ask, why that blue?
Why the blue?
Why that blue?
Well, yeah. I don't know how much Sunil knows. Is Sunil a doctor?
It doesn't say. I don't believe so. I don't know.
All right. Well, Sunil, the answer is this is a very specific compound that we inject, and it has a blue color. And it is the only compound that specifically stains degenerated nucleus pulposus. There are other blues, you're right, but this is special. It's special because it binds to the nucleus. Other blues don't. Okay? That's the answer. There's another piece of herniation right there.
Sunil commented he is not a doctor. He is a businessman from North Carolina.
Ah, Sunil, nice to meet you. But that's the reason why, Sunil. The blue dye that we use, a specific molecule or compound, is has a binding affinity or likingness to hey, is that his arm moving?
No, that's me.
To degenerated nuclear material. Remember, nucleus pulposus is primarily made up of what are called proteoglycans. Proteoglycans are polymers of protein, and glycan is sugar. So they're sugar proteins, and they primarily have long chains that bind water. Okay? So we call that hydrophilic. And hydrophilic things like water. Hydro is water, philic is loving. It's Latin for philus, I guess, or maybe my son Arius could give us the Latin name. But philic means to love, and water-loving molecules bind to water. And if you remember, the middle of the disc, the nucleus, is primarily made up of water, around 80%, 90% water. So these proteoglycans in the center of the disc, in the nucleus, they basically degenerate over time, break down, and they become acidic. Acidic is not the same as Hasidic. It is acidic. Acid means a low pH, high hydrogen ion concentration. So the acidic nature of the nuclear material means that it binds this dye. In other words, the blue dye becomes sticky when it's in an acidic environment, like the center of a degenerated piece of nuclear material, which is what we're removing from the herniation. Great question. I hope that answers it for you. All right. He's moving a little bit, but I'm okay with it, Doctor Berndes.
We have a couple more questions.
Sure. Yeah, I know, every patient, right?
No, he did this. First patient.
Go ahead, I'm listening.
The question, this comes from one of our viewers from China, I believe, from Facebook.
Excellent. Welcome, our
And-
Chinese friend.
And they ask, how many discs need to be burned?
I could not understand the question. How many discs are we doing?
I believe how many discs need to be burned for this procedure?
Burned. Well, we're fixing 2 discs for this one. 2. L3-4 and L4-5.
And our next question comes from Sunil Patel on Facebook. And they asked, how painful is this surgery?
Great question, Sunil. The surgery is painful if we don't have anesthesia. But with the anesthesia, it's not painful. And it doesn't hurt me at all to do the surgery. Hopefully you can appreciate my sense of humor. It's not a painful surgery, Sunil. Every other open surgery in the back is much more painful, much more damaging. This surgery is minimally damaging to the body, therefore it's minimally painful. the pain that people get after spine surgery, it comes from the muscle. You doing all right, Dr. Berndes? Here, we're pretty much done here. Let me grab that last piece. So most pain from spine surgery, believe it or not, it actually comes from muscles that are being damaged from the surgery. And since our surgery does not damage muscles, there's no pain. Our patients literally have soreness in their back from putting this tube in for maybe 1 day. And they take Tylenol for pain. Nothing more than Tylenol and a muscle relaxer. We don't need narcotics like open spine surgery does. So there's no opioids, there's no sedatives or powerful painkillers at all, just Tylenol, which you can buy in the store. Yeah, I'd be happy to do that. We use betadine to cleanse the wound, which is developed by NASA, and then saline to clean out the betadine. Now we're going to take the tube out. Patient will be happy about that because that's not going to be comfortable.
Yeah, and the ceiling off, please. Thank you.
We're going to move to the next disc.
Thank you. Yeah, come. Yeah, keep coming. Yeah.
Now if you notice, I'm putting some pressure on his back. I'm putting pressure on the muscle. Remember, the muscle sometimes can bleed a little bit, small amount, and by putting pressure, we can stop that bleeding. We don't want any blood inside the muscle. If there's blood inside the muscle, the patient will have pain in the muscle for several months after the surgery. And the pain comes from muscle spasms due to the breakdown of the red blood cells and release of hemosiderin, which is a metabolic byproduct of the breakdown of red blood cells by macrophage, which are an inflammatory cell. And
You might need a little stimulation right now.
are you serious? Lateral shot, how much? Help me. Come on, hold that pressure, hold pressure on the blue, Shot. Mallet. Shot. Shot. You got to get rid of that white up there. You know what that takes? It's called collimation. Come on. It shouldn't be in the field of view. You're basically irradiating us. There you go. That's the things you got to do on your own without me telling you. Is that helping him or not?
Yes, it is.
Shot? Yeah. All right, that's it. So we're inside the next disc. We're there. The tube is in place. I don't feel any hematoma in the muscle. Feels good. Let's try to keep his blood pressure no higher than it is. Okay. Those are great questions we've had so far. We're going to go in now and do our second disc. 2 of 2. All right.
Lights off, thank you.
really see the herniations as much here as I did in the last one. The last disc had a lot of herniation. How we doing? Come on, man. You got to be on top of it. You got one job there, my friend. Pay attention to the laser fiber. All right, do you have any questions, Henry?
No current questions.
There's the tear right there. You guys see the annular tear? Pretty cool, huh? We need 5 minutes, we'll be done.
We just needed the choke collar, so we fixed everything.
You're pretty funny.
We have a comment from YouTube.
Yes.
This comes from Debbie McMichael.
Hello, Debbie McMichael. Welcome to our live stream at Duke Spine.
They said, "Hello, Dr. Duke. I will be sending you a copy of my MRI for you to let me know if you will be able to correct my back pain."
Of course. Thank you. Yes, can you post the link, please, Henry, for everybody that wants to send us any copies of any MRIs of the back or neck? We're happy to do a MRI review. It's free. We don't charge for it. We try to do it as a community service for people around the world that are looking for answers, because we understand it's so hard to get a straight answer from your doctors. Unfortunately, most of them cannot make the right diagnosis. Without the right diagnosis, you're guaranteed to not get the right treatment. So at least with a diagnosis, you'll know what's needed, and maybe you can get your surgeon where you live to do what they should be doing to help you. All right, we're 5 minutes away from being done. I've already notified my anesthesiologist. He's aware. This is the outer part of the disc right here. I'll show you how I know that. You see right up there? See those thick white fibers and that thing? That's a vein. Those are veins right there. And these thick white fibers going side to side are the posterior longitudinal ligament fibers. It's a ligament that runs in the back of the spine. There's a little bit of epidural fat there. Grab her. What's on the table? Suture? Come on, man. Come on, come on, come on. Oscar. Oh. You know, it's that time of year.
We have a couple more questions.
All right. I'll take the questions.
This
I'll
first
take however many questions I can get to. And then if I can't get to them, I'll come and do them in the conference room face to face.
Copy that. This first one comes from Derek Olson on Facebook. And they asked, can Dr. Duke explain bursitis in the hip, and does the pain going down the leg come from the hip or lower back? My wife gets shots in her hips from the pain.
Okay, Mr. Olson, thank you. Bursitis is basically, anytime you see an itis at the end of something, it's inflammation. So bursitis is inflammation of the bursa. And the bursa is a cushion on the side of the hip. You got one on the left, one on the right. And if you're not walking properly, if you're walking off center, you know, with a bad gait, a bad posture, then you're favoring one hip over the other. That's going to make the bursitis act up and cause really bad pain. The bursitis pain never goes down past your knee. It only goes down about, maybe all the way down to the side of your thigh, but never past your knee. So if it's going past the knee, there's something else going on. 30 seconds. You could have iliotibial band syndrome, which is ITB, iliotibial band. It could be sciatica. It could be the piriformis muscle causing that pain. 20 seconds. So she needs a proper diagnosis, Derek. And it's hard to do without the doctors really knowing those different diagnoses. But a physiatrist is the best one for that. Great question. But trochanteric bursitis never goes past the knee. We doing all right? Huh? We're done.
We'll get through it.
I can be done.
We're gonna get through it.
You need me to be done?
We're okay. Stats when you do.
Literally, I mean, I cleaned it all out, so we're pretty good.
Eyes on, please.
I'm just doing like gilding the lily at this point.
Thank you.
Let me do one more grab in there.
Yes, sir.
Sometimes you get a piece of herniation that's hiding in there. And that's why I like to make sure I've grabbed. Looks pretty good. Are you all right? Berndes?
Yeah.
Am I need to be done?
Yeah, we're okay.
We're done.
All right, go about
Take.
pain. Thank you.
All right, so a challenging case for my anesthesiologist. Everybody's a little different. All right, we're all done. You're waking up. Don't move.
No. He has no sleep diagnosis. We just gave it to him.
And I'm going to come answer the rest of those questions. Oh, I don't need any more.
No? Okay.
When I get over there, okay? So type your questions up for me. We're done, yeah. Type your questions up for me, folks, and I'll be happy to answer them for you in about 5 minutes, all right? Take it out. Good job. I'll hold this while you. So we lost about 2 cc's of blood, which when you're doing open back surgeries, you're going to lose around 200 to 500 cc's. So that's probably around 1% of the typical volume of blood loss. Here, take it. Right here, take it. Right here, take. I got it. Let go. You got it? Just take it. You're good. You'll clear the lines. Just go. There you go. See? All right, you want to see the incision, Henry? Show our audience the incision. Look at that. Henry, you see this?
We see it.
All right, are you still on me live or are you on a video?
No, we're live. We're still going.
All right, why don't we go to a video and show them the alternative to Deuk laser disc repair for painful back disc, which is fusion. But it's got to be a certain type of fusion where we clean out the disc and fuse the bones in between where the disc was.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place, and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
It's Dr. Ari Deuk-Majan at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well,
and I came in with a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
Yeah, and I'm A1 now.
Awesome. So you had your surgery. You've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too. When you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
not too soon with any of that lifting engines.
All right, yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it, because you're going to get better. You're going to get better.
Well, Congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, Doc.
It's Dr. R. Deuk. Hi, Dr. Deuk Majan here.
Oh, no.
Oh, no.
There we go. Yay. Cool.
All right.
We got it.
We're still figuring this camera out, but sometimes even the camera doesn't want to see my face, so bear with us. That said, we are done with the surgery. It went very well for those of you who watched. Our patient was interesting in that he was very, very sensitive even to a pinprick. You saw when I put the medicine in, he was wiggling around. That does happen from time to time. We have everything you can imagine from one end of the spectrum to the other. Some patients just lay there. They don't need much anesthesia. They don't move. They're perfectly comfortable, sleepy, happy. Other patients are very sensitive to pain. Even the smallest little pinprick sets them off into agitation. So we can never tell who's going to do what ahead of time, but this patient was particularly sensitive even to the injection of the pain medicine under his skin. That said, we did the discograms as we always do. However, he was asleep for the discogram, so I still need to do the discogram in order to inject the blue dye into the disc so that I could stain the degenerated herniations, the blue things, and get rid of them. You saw on the first disc that I treated, we had a lot of herniations, many pieces that were there, and I got them all out. The second disc had fewer herniations, only maybe one or two, small ones. So very different architecture of the two discs, but the pathophysiology is the same. It doesn't matter whether you have a lot of herniations or just one. The pain comes from the tear, and you could see the tears were pretty much identical. They had a lot of scar tissue. They had some nuclear material stuck in there causing inflammation and pain. I went in with the laser and cleaned them both out with the debridement. It was very successful. I think this patient's pain will be gone. Now our first two patients are already home. They're on their way home or home. And this patient we just finished now will be probably going home in about an hour. It takes an hour to recover from the surgery and an hour basically to go home. Now, patients cannot drive the same day as their surgery because they've had anesthesia. So they all have to have a driver. This is why we encourage people who travel to bring with them a family member or friend that can drive them. Also keep an eye on them the first night. Our next patient is coming from Michigan, and she has had many back surgeries, including fusions, and again, just the saddest story. It's something I hear all the time, totally mismanaged by their doctors. She injured her back at work. She started to get numbness in her legs from a herniated disc pushing on the nerves causing stenosis. She complained to the doctors. They ignored her. They told her it's okay. They gave her medicine, pain medicine, especially something called gabapentin or Neurontin, and it's a nerve stabilizer. Folks, you don't treat a pinched nerve with medicine. The pinched nerve is telling you something. There's something wrong. When you have a pinched nerve, you treat it by unpinching it. The problem is there are so many doctors that either don't understand that or don't care, and they just want to write their patients for pain pills instead of giving them the right treatment. The right treatment is surgery. Whenever you have a pinched nerve, the right treatment is always surgery. Okay, so she didn't get surgery because her doctors gave her pain medicine instead. And she got worse and worse, and she said finally she was pooping on herself and peeing on herself. That's when the nerves are so badly damaged from pressure on them from the herniated disc, they just stop working. And people will poop and pee on themselves. She said only then did they realize I needed surgery. So they took her to surgery in Michigan, and she went to a very good hospital, and they actually did a very good decompression. I looked at her MRI or CAT scan, all the pressure's off the nerves now. They did a fusion. So they got a decompression and a fusion done with screws and rods, but now she's having pain below the fusion. And you should see her back. It literally looks like a tic-tac-toe game with all the scars from the prior surgeries. Poor thing. She's here now at Duke Spine because she's still having pain. It's coming from below her fusion. We're going to go in and try to do the Deuk laser disc repair at L5-S1, and we're going to treat the L5-S1 facet joint. She has a combination of two problems. Problem number one, I can't find my paperclip. Somebody has stolen it.
No, it's right here.
We need to put out the APB. Stolen paper clips, very valuable. So here's the problem. She's got the fusion, but the fusion stops right above the last disc. So this last disc is now the problem, and the facet joint is the problem. Pain is coming from both structures. The Deuk laser disc repair does not fix facet pain. It only fixes disc pain. So I recognize on her exam she had facet pain as well. We're going to be doing a Deuk plasma rhizotomy, treating the medial branch of the dorsal ramus at that last level. We're not ready to broadcast the Deuk plasma rhizotomy. We are very close. So in the next few months, probably January of 2023, I will be showing you for the first time the most advanced treatment in the world for facet joint pain. Everyone else does something called a radiofrequency ablation. We have developed a new technology called plasma rhizotomy. It doesn't use your blood plasma. It uses plasma energy, which is an electrical charge directed into tissue that converts a solid tissue into a gaseous form called plasma, high energy gas called plasma. You may recognize that as a neon, if you remember your neon signs. The gases that are in a neon sign are in the royal family of gases, and they are noble family, and they basically energize and glow and emit light. And neon signs are something from my generation, from the 80s and 90s, but I don't think there are too many neon signs anymore, right? We use billboards now.
I have one.
You have a neon sign?
Yeah.
Very good. Well, basically we're talking about plasma, which is energized gas, and that is the technique that we use to treat the painful facet joints in the back of the spine when people have facet joint pain. Why do we do it? Because the problem with radiofrequency ablation is it wears off, and people come back every 3 months, every 6 months, they have facet pain again. It's not a durable treatment. And of course, the companies that make the products for that treatment, they want that because they want patients to keep coming back so they can keep selling the doctor more needles and more probes. Well, at Deuk Spine Institute, our philosophy is different. We want to cure pain. We don't want to treat your pain, we want to cure it. So we don't use pills, we don't use shots, we don't use surgeries that don't work, we use surgeries that cure pain. And that's our goal, is to cure people's pain so they don't never come back. Okay? That said, I think we have a question or two.
We have a few. Yep.
So I'll start by answering the first question.
The first one comes from Sunil Patel on Facebook. Once
Hello,
more.
Sunil.
And they ask, is that patient, will they feel burned from the inside during the laser surgery?
Great question. Will the patient I just treated, or any laser surgery patient, do they feel burned from the inside? The answer is no. I know it sounds crazy, but did you see any char tissue? So char is blackened tissue, blackened, like when you're cooking a steak, you know how it turns black on the outside from being burned? Did you see that? The answer is no. And the reason why there's no char is because we're bringing irrigation fluid, cold irrigation, through that tube constantly. And when you notice when I use the laser, it breaks up the herniation into little pieces. They float out quickly because I have a flow going through that tube of cold saline, refrigerated. So the cold saline cools the tissue so there's no burning. Everybody thinks lasers burn, but they don't. Well, if you don't use it right, they will burn. But at Deuk Spine, we use it properly, and there is no burning of tissue.
All right. These next two are comments. They come
Great
from...
question, by the way, Sunil.
Of course. These next two are comments from Deuk Olson and then one of our viewers from China.
Sunil, you keep coming back because you're asking good questions.
And they said, both Derek and one of our viewers from China. They both said thank you, doctor, and it's always so helpful.
My pleasure. I'm glad you all were here today, and I hope you can learn something from our surgery. I enjoy teaching, and there's a lot that needs to be taught out there. A lot of people that need to learn the truth. So spread the word, and we'll be back for one more surgery in a few minutes. So we did get a question, I guess.
We do have
Just under the gun.
Yeah, just under the gun from our from YouTube, John Doe.
Hi, John Doe.
And they said, hey, Dr. Duke, I'll be sending you my MRI once it's ready. Should be December 6th. I'm scared, doctor, because when I saw my x-rays, the disc at L5, it's gone from what the chiropractor says. The herniation is at the front of the disc, and that there may be some disc tissue on the nerves, which is causing the nerve pain and sciatica. And that if someone could clean that tissue off the disc, I should be fine. I told him I'm going to do my best to come see you. I'm trying to stay strong, doctor.
John, stay strong. I promise you we can fix your pain. It is not the herniation in front of your spine. That never causes back pain. The reason is, I'm going to show you a secret that nobody knows, but I've taught it. This is your disc here. The front of the disc and the sides of the disc are innervated by a type of nerve fiber, a pain fiber called a visceral afferent, or VA, visceral afferent. Visceral afferent fibers never go to the part of the brain where you can feel sharp pain. They only go to the brainstem and the limbic system through projections through the thalamus and the brainstem. Basically, herniations in the front and sides of your disc never cause pain. The back of the disc has nerve fibers called somatic afferent fibers, SA, not VA, SA. And somatic afferent fibers are only special because of where they go. They go to your primary somatosensory cortex in the parietal lobe, the sensory cortex. You have a little homunculus or little man on your brain, and every part of your body from your toe to your nose is projected onto that primary somatosensory cortex. And this is something that we discovered here at Deuk Spine, that the back of the disc, posterior annulus, is innervated by somatic afferent fibers that project to the primary somatosensory cortex. Therefore, it's only posterior tears and herniations that actually cause conscious pain, pain that you're aware of, highly localized pain, okay? So fear not, we can fix your disc if you want. Don't worry about the fact that it's collapsed, that's not important. If I get rid of your back pain at L5-S1 with my laser surgery, you'll have zero pain. You can go on and live an absolutely normal life with no restrictions, okay? I look forward to getting your MRI. All right, we'll be back in 30, 40 minutes with our last surgery for today, a single level L5-S1.